Dear colleagues, today I will show you the case of a fetus presenting with a condition compatible with intestinal atresia. Intestinal atresia is defined as a congenital obliteration of the lumen of segments of the small intestine, which can be classified into different types based on the nature of the anatomical obstruction. The incidence is about 2 to 3 cases per 10,000 live births, with the following distribution. In 50% of cases, it affects the jejunum, and in over 30% of these, the proximal segment. In 43% of cases, it affects the ileum, with over 30% of cases involving the distal segment, and in 7% of cases, multiple jejunoileal forms are observed. From an ultrasound perspective, the typical finding is the dilation of the intestinal loops upstream of the atretic segment. This appearance can also be similar to that of intestinal volvulus, often making it difficult or impossible to precisely determine the location of the small bowel obstruction. In general, the more numerous and dilated the intestinal loops are, the more likely it is that the obstruction is distal. In most cases, polyhydramnios is present, and it is more evident when the obstruction is proximal. However, the main ultrasound signs, namely the dilation of the loops and the increase in amniotic fluid, rarely appear before the 24th week of gestation. It is believed that, in most cases, intestinal atresia is caused by an ischemic event such as a vascular accident, or even a volvulus intussusception, or a vascular malformation. The most widely accepted classification distinguishes several forms. Type 1 is characterized by the presence of a mucosal diaphragm that obstructs the intestinal lumen, with the intestinal walls remaining intact. Type 2 presents two blind-ended intestinal segments connected by a thin fibrous band. Type 3, on the other hand, is characterized by two separate intestinal segments with no continuity, and it is the most common form. Type 3, also known as apple peel atresia, is a rare and severe form, often associated with familial transmission. It involves the distal duodenum, the entire jejunum, and the proximal ileum, and is believed to be related to ischemia caused by occlusion of the superior mesenteric artery. In 42% of cases, associated anomalies may be present, including intrauterine growth retardation in 30% of cases, meconium peritonitis in 12% of cases, meconium ileus, cystic fibrosis, omphalocele, as well as gastroschisis, cardiovascular defects, and chromosomal abnormalities, in addition to imperforate anus in 5% of cases. Most of the associated anomalies, however, involve the gastrointestinal tract, while extraintestinal anomalies are less frequent. And this supports the hypothesis that intestinal atresia is often the result of an acquired vascular injury rather than a primary defect in embryogenesis. Several associated genetic and chromosomal syndromes have been described, including rare autosomal recessive forms. As for the differential diagnosis, this mainly involves distinguishing it from intestinal volvulus and meconium ileus. It is also important to be careful not to confuse intestinal atresia with other cystic abdominal masses, which must in fact be ruled out. Regarding the fetus under examination, this is a pregnancy at 38 weeks of gestation, in which the fetal biometry is appropriate for the gestational age, with an estimated fetal weight of about 2 kilograms and 900 grams. However, the findings are compatible with intestinal atresia. In fact, dilated intestinal loops are observed with a maximum diameter of about 35 millimeters. A noteworthy element is the presence of intestinal peristaltic activity, which is an important factor for the differential diagnosis with other neurological or myopathic conditions, such as intestinal ganglionosis. Furthermore, the contents of the loops do not appear particulate, and this is also a relevant aspect, since evaluating the density of the intestinal contents allows us to rule out other associated conditions, particularly cystic fibrosis, in which a denser and thicker content is typically observed compared to what is seen in the fetus under examination. At the gastric level, in the fetus under examination, a pseudomass is observed. However, this finding does not have pathological significance, but simply represents the presence of vernix caseosa in the fetal stomach and is therefore a physiological finding with no clinical relevance. Continuing with the evaluation of the fetus under examination, there is no ascites, no abdominal calcifications are observed, and there is no polyhydramnios. Although polyhydramnios is frequently associated with intestinal atresia, its absence does not rule out the diagnosis. In this case, in fact, even though this finding is absent, the overall ultrasound picture remains highly suggestive and decisive for intestinal atresia. It is important to emphasize, however, that in cases of intestinal atresia, it is not possible to determine with certainty the exact location of the obstruction during the prenatal period. The location, in fact, can vary, and in some cases, there may even be multiple sites along the small intestine. Ultrasound can provide suggestive elements, but it does not allow for a precise anatomical definition of the location or the extent of the affected segment. In general, however, as mentioned earlier, the rule is that the more numerous and dilated the loops are, the more likely it is that the site of the obstruction is located distally. Another aspect, no less important, is the absence of evident associated anomalies. However, it is important to emphasize that the patient was observed for the first time at 38 weeks of gestation, which is a stage when the sensitivity of ultrasound in detecting associated anomalies may be lower compared to examinations performed at earlier stages. Despite this limitation, no associated structural anomalies were identified. Furthermore, the placenta appears to be normally positioned and has a regular structure. As previously mentioned, the amniotic fluid is present in a normal amount, and the fetal Doppler studies are within normal limits, indicating proper fetal-placental hemodynamics. With regard to the management of this case, since the patient has already reached the 38th week of gestation, it is essential to recommend a pediatric surgical consultation so that, at birth, the newborn can be immediately evaluated by a pediatric surgeon. It is also essential that the delivery takes place in a facility equipped with a neonatal intensive care unit capable of providing adequate and timely assistance. As for the prognosis, in isolated cases, it is generally excellent after surgical correction. On the contrary, it is less favorable in proximal jejunal forms, mainly due to the higher incidence of prematurity and the possible associated complications.
Now you can see the postoperative findings. The surgery went well. There were no complications and our diagnosis was confirmed. It is always important for you to collaborate with the pediatric surgeon, both before and after. Thank you for your attention.